This lesson is about acute respiratory distress syndrome, more easily called ARDS. And let's talk about that pathophysiology of ARDS. So ARDS is a progressive respiratory failure usually seen after a lung injury or multisystem organ disease. I'm thinking sepsis or maybe COVID-19. What happens is that my alveoli membrane becomes more permeable to fluid. So normally it's O2 in, CO2 out, but now I have fluid, which impairs my gas exchange. I also have decreased lung compliance, so I'm thinking stiff lungs. These patients have a high mortality rate, and it's very important that we catch these guys early. So let's dive in a little deeper. When talking about the pathophysiology of ARDS, we really need to talk about cytokine storm. Now, what this is an acute systemic event that triggers a rapid release of cytokines, or inflammatory cells, and they actually target the alveoli and the pulmonary capillary system. What ends up happening is there's severe swelling and destruction of the alveoli and surrounding capillaries. So I have surfactant destruction, surfactant we need to even keep our alveoli open, and all this fluid that will rush into the lungs and surrounding tissue. What are the risk factors for a patient with ARDS? Well, you could have bacterial or viral pneumonia, or even aspiration pneumonia. We've mentioned sepsis, acute pancreatitis because it's so inflammatory, it can actually attack your lungs. Submersion injuries, so I'm thinking maybe a patient is near drowning, severe burns and trauma. So what are some clinical features of a patient with ARDS? They're going to be short of breath. This is because they are hypoxic. They can have refractory hypoxemia, meaning no matter how much O2 I give them and turn up, their pulse ox continues to drop. You'll see compensatory tachypnea, so we're breathing faster. There's intercostal retractions, so lungs in and out, accessory muscle use, shoulders up and down. They're definitely going to be anxious if they're awake, tachycardic, and we may see fever because of infection or even just inflammation. You will hear crackles on auscultation because not only are they having fluid in the alveoli, it is in their lungs, think pulmonary edema. What diagnostics will happen for a patient that's in ARDS? So we're going to draw some ABGs, and most likely we're going to see hypoxemia, so a low PaO2 under 80, and they're going to be in respiratory acidosis. If blood gases throw you off, make sure you look at those lessons. Expect a chest X-ray because we're going to see diffuse infiltrates, meaning fluid everywhere. What are nursing interventions for a patient with ARDS? We need to administer oxygen, and hopefully it works. We're going to place that client in Fowler's position to help them breathe. Expect these patients to be on a ventilator with PEEP. We need that pressure to open up the alveoli so they can have proper gas exchange. Remember, guys, restrict those fluids. They have tons of fluids in their lungs. They don't need extra. We need to provide and monitor sedation and paralytic support. Remember, they're on a vent. We have to keep them comfortable and calm. Make sure that we're feeding these patients with enteral nutrition support, and we might have to put them prone, meaning face down. What this does is it drops the mediastinum and it allows recruitment on those lower lobes so your patient can breathe and have better gas exchange. Typically, when we put these patients in prone, you'll finally see their O2 sat come up. Anticipate ECMO for these patients, which is basically a bypass machine. Remember, their lungs and heart are now not working properly. While the patient is our number one concern, don't forget about family. Remember, mortality with these patients is very high. Now remember, once our patient is intubated, they're at high risk for clots. So we're thinking DVTs, we need to make sure they give anticoagulants and their SCDs on at all times. Remember, our patients' alveoli are closed. They're going to require PEEP and that prone positioning. We have to monitor for ventilation-associated complications, so I'm thinking barotrauma, so a pneumothorax. We have a great lesson about that. Hypotension, delirium, stress ulcers in the stomach, and even acute kidney injury. So we're going to be checking those ABGs frequently. That's going to tell us how our prone therapy and PEEP is working for an ARDS patient. Speaking of acute kidney injury, make sure that we're monitoring output and report if it's under 30 milliliters an hour. Anytime we suction any patient, please remember to always turn up the oxygen to 100% so we don't make them hypoxic. Let's talk about the long-term consequences of ARDS. Remember, there are 3 phases and they take a couple weeks to get through. We have that rush of fluid, all the inflammation, and then finally that fibrotic, hard alveoli. And this is permanent. This is why it's so important for you to recognize ARDS early so we can keep our patients safe. Great job, you guys. ARDS is really tough, but I know that you could get through it.